Just a little recap of some of the things we've covered already. Generating an action potential in a muscle cell requires that the cell be polarized at its resting state, which means there's a difference in charge of ions across the membrane, more negative inside than outside the cell. Because of that, the cell can become depolarized, which means to change those charges so that the inside is now more positive. That happens as a result of acetylcholine being released from those motor neurons and binding to the receptors. When the receptors on the muscle cell bind the acetylcholine, ion channels open and sodium rushes in. Remember, sodium is positively charged, so that makes the inside of the muscle cell more positive. That area of the muscle cell then depolarizes, and then neighboring areas of the membrane depolarize, and it spreads sort of like a domino effect, leading to an action potential in a muscle cell. As the muscle cell is depolarizing, remember, we've got sodium ions coming in. That's changing the charge across that membrane. And then we have all of the actions that we just talked about with the calcium coming in and changing the shape of the troponin and opening up the binding sites. So if you don't remember all of that, be sure to go back and review the video that shows you the role of the sliding filament theory. Now, once all this has happened, if that cell is ever going to contract again, it must become repolarized or set back to its normal state of resting polarization. This happens because sodium and potassium channels and pumps open and move that sodium, most of that sodium, back outside the cell, moves some potassium back inside the cell, and restores that electrical and ionic concentration or condition across the membrane so that the cell once again becomes repolarized. Now that cell is ready for the next action potential. So if another nerve impulse is released and causes more acetylcholine to be released, then the cycle repeats. Well, it's not wanting to move. There we go. So muscle cells do, of course, have to relax. This happens when the action potential has ceased and no more acetylcholine is released into the synapse. If the acetylcholine is not released into the synapse, then calcium is going to be pumped back into the sarcoplasmic reticulum for storage. The tropomyosin then will go back to cover the binding sites because the calcium has been removed from the troponin. Once that happens, of course, the myosin heads can no longer bind to the actin, and the muscle cell relaxes and becomes lengthened back into its normal state again. So I thought this might be a place to add in a little bit of clinical application and break up some of the muscle contraction hardcore details. Have you ever thought about what rigor mortis is? After death, cell membranes become very leaky and the calcium ions leak out of the sarcoplasmic reticulum into the sarcoplasm. So remember what happens when we have calcium flooding the sarcoplasm. The myosin heads can then bind to actin because the calcium bound to the troponin move the tropomyosin, right? So the binding sites are empty. Now, we've got the myosin heads bound to the actin, but because breathing has stopped, we're no longer getting oxygen in, right? So we stop making ATP. When the ATP is no longer made, we can't detach those cross bridges from the actin. So the resulting condition is the muscles are in a constant state of rigidity. They can't contract, they can't stretch, they can't relax, and that's what we call rigor mortis, or the rigidity of death. This usually begins about 3 to 4 hours after death, with the peak of rigidity about 12 hours after death, but then it tends to disappear somewhere about 24 hours or so after death because all of the enzymes start to break down those proteins and break down those cross bridges. A couple of additional things that I thought were really interesting when we're looking at muscle contraction excuse me, are the way that some of the drugs and toxins work. So there's several plant products and drugs that can selectively block some of the actions at the neuromuscular junction. The botulism toxin, produced by a bacteria, blocks the release of acetylcholine. So if acetylcholine can't be released, then muscle contraction can occur. The botulinum bacteria, which you don't necessarily have to know the name of it, but it is a bacteria, is able to proliferate or reproduce in improperly canned foods or things that have been opened and not sealed back properly. And their toxin is one of the most lethal chemicals known, so even a tiny amount of it can cause death by paralyzing some of the muscles associated with the respiratory system, such as the diaphragm. However, because we have been able to study its action and learned quite a bit, it's also the first bacterial toxin to be used as a medicine. I'm sure you've all heard of Botox. Injections of Botox into affected muscles can help patients who have cross eyes or uncontrollable blinking or spasms of the vocal cord that interfere with speech. Can also be used to alleviate chronic back pain, because a lot of back pain is due to muscle spasms in the lumbar region. However, its most widely known about use is as a cosmetic treatment. Excuse me. As a cosmetic treatment, it can be injected into some of the facial muscles and cause those facial muscles not to be able to contract, and that relaxation helps to get rid of some of the facial wrinkles, or not to be able to do as they should. So it's used to treat or quote-unquote cure wrinkles. Really doesn't cure it, because they do come back once the medication wears off. There's another poison called curare that's used by South American Indians on arrows and blowgun darts. It causes muscle paralysis by binding to and blocking acetylcholine receptors. So in the presence of curare, the ion channels can't open. These curare-like drugs can also be used during surgery to relax skeletal muscles, so there is a pharmaceutical use to this as well. And then there's a family of chemicals called anticholinesterase agents. So they slow down the activity of the enzymes that break down acetylcholine. So if you're not breaking down acetylcholine, it stays in the synaptic cleft longer. At low doses, these agents can strengthen weak muscle contractions. One example of this is neostigmine, which is used often to treat patients with myasthenia gravis. We'll talk about that in the homeostatic imbalances in the nervous system. But it can also, because of the way that it slows the removal of acetylcholine, keeps that acetylcholine in the cleft, it can be used as an antidote for curare poisoning or some of the curare-like effects of drugs after surgery. The neostigmine can help them to retain their function or go back to normal.